Um, Şimdi değerli meslektaşlarım 35 kişi olduk. Yavaş yavaş yani artıyordur bu sayı gün klasik. Şimdi Samuel Santos Ribeiro şu anda EVRMA Lisbon'un işte bilimsel direktörü. EVRMA şu anda dünyadaki yani hem merkez sayısı olarak hem de akademik çıktı olarak en büyük zincir. 2 yıldır ASRM ve ESHRE'deki neredeyse bütün ödüllerin tamamını alıyorlar orijinal research çıktılarıyla. Ama Samuel'ın bugün sunacağı çalışma EVRMA'deyken yapılan değil. Birazdan kendisine söyleyeceğim. Eğer yanlışsam düzeltir. Samuel Fellowship'ini Brussels Free'de yapmıştı. Christoph Blockiller'le ve hani oranın döngüsüyle çıkan çok sayıdaki çalışmadan birisi. Samuel'in 70'e yakın makalesi var ama hepsi gerçekten high impact. Aslında birçok günlerde konuştuğumuz işte bu donmuş embriyo transferi, doğal siklüs, yapay siklüs, yok doğal siklüste progesteron ekleme falan, onların çoğunun yazarı Samuel. Bugün konuşacağımız konu da yaklaşık 5 yıldır sürdürdükleri, belki 6 yıldır sürdürdükleri, Bülent abi hatırlayacaktır hatta biz de katılalım mı diye değerlendirmiştik ama hasta bulmanın çok zor olduğu bir randomize kontrollü çalışmaydı. Yani yüksek yanıt veren hastalarda 10 yıl önceden beri işte analog trigger ver, arkasından da taze transfer için 1500 ünite HCG ver, taze transfer yaparsan bu güvenli bir şey gibi görülüyordu. Yaptıkları çalışma bu yöntemle analog trigger verip tamamen dondurmanın hem güvenlik hem etkinlik sonuçlarını karşılaştırdılar. Randomize kontrollü bir şekilde 200'er hasta var neredeyse. Brussels Free gibi ayda 500 IVF yapılan bir yerde bile bu randomize kontrol çalışma 5 yıldan fazla sürdü ve yakınlarda yayınlandı. Bence sonuçlarının günlük pratiği yönlendirmekte önemi var. Samuel şimdi o çalışmalarının bağlamında bu konuda bir konuşma yapacak. Arkasından ben bununla ilgili hani o çalışmanın da ötesinde biraz timeline'ı, biraz literatürdeki diğer verilerle birlikte bizi nereye getirdiğiyle ilgili görüşlerimi söyleyeceğim. Arkasından da hani soru cevabı uzunca bir zaman kalacak. Samuel, I introduced you and I'll tell you what I've been speaking for so long. First, I told that you've done your kind of fellowship training at Brussels Free. Now you are the scientific director of EVRMA Lisboa. EVRMA is the largest chain, biggest chain, not only like caseload wise, but with regard to academic production. And I told my colleagues that you have close to 70 original publications, most of which are really high impact papers, which we've been citing and discussing over our previous meetings. And I've explained that we'll be discussing how to manage the hyper responders, what is the best way with regard to safety and efficacy. And I've also mentioned our memories about how to recruit patients for this like 5-6 years long trial. Okay. And now the floor is yours. We're looking forward to your lecture, and take your time. Thanks for coming.
I really appreciate your kind introduction and the invitation and opportunity to be with you guys all today. I hope that over this upcoming hour, we'll be able to speak freely about this topic and about the freeze-all approach as a whole, and also the opportunity to talk about what to do in patients which obviously, as we know, want to conceive as efficiently and as quickly as possible. However, as a small introduction, I will be discussing a little bit of how ART has been evolving after, in which I will dive in directly into the topic that we'll be talking about, which has to do with how to efficiently treat those predicted high responders. And well, one of the questions that comes on to our day-to-day basis is ART a complicated procedure? And I don't know if this image summarizes what you guys feel when it comes to IVF, but it does really summarize in one figure what I feel when I'm doing my IVF procedure. And basically what it shows is that my day-to-day is thinking about 300 or 400 variables to maximize efficiency but safety trumps it all. So I can make the perfect embryo and guarantee conception to a patient if she has the minimal complication, as they are young patients and generally otherwise healthy. One safety issue is so much more important and trumps all the very good things you might have been done before. So it's really important to discuss safety of ART because patients really evaluate it and think it is important. And when you look at this in terms of results of how safe is IVF, one thing you are going to notice is that OHSS stands out a lot and that it's a really important outcome. So it's the enemy number one. If you think of ART in terms of complication, well, actually, the one you should be caring about is OHSS. Most importantly is when you actually have OHSS, it seems like all the other complications come with OHSS, and actually 73% or 82% of them are either directly OHSS or OHSS related. So it's really important to eliminate this enemy from our site and to be sure that you don't see OHSS and that it becomes an OHSS-free clinic. And well, the first thing that we did to try and avoid OHSS was to try and increase the use of agonist trigger and of antagonist cycles. And this is indeed the first prevention method that really makes things better. And it happens because there is a different mode of action. Instead of you causing a flare-up and then a down-regulation after this flare-up, what you actually have with the antagonist is a direct suppression. Now, for the few centers that still perform agonist cycles, I would like to speak with you for 1 minute. And I would like to first agree with you and say, yes, there are still studies, still meta-analyses showing that the diamond, the overall results might work a little bit in advantage of the agonist cycle and might be giving you one extra egg if you perform an agonist cycle. My question to you is, let us look at IVF as a broader perspective. And if you are still doing a lot of agonist cycles, let me discuss with you if that egg makes a real difference. Well, it doesn't seem from these meta-analysis when it looks at live birth rates that it does make some. However, those that are still performing a lot of agonist cycles will argue that, well, it doesn't show a significant difference, but the diamond is still on the advantage of the agonist cycles, so I'm going to continue doing my agonist cycles. Well, I would invite you to look at this data of antagonist versus agonist, and I hope that in this next 2 minutes, I will be able to convince you that you should be performing more antagonist cycles by trying to convince you that things have changed over time. And if you have looked at this graph from Lambalk, which is the last meta-analysis, one thing you will notice is that he presents the data and the authors by their first name. So you see that the Albano paper is first and the Yi paper is last. I'm going to propose to you to look at the exact same meta-analysis and the exact same studies, but putting the 2000th year study above and calling them the studies of the past, and putting the studies from 2010 onwards as the studies of the present in the bottom. And if you're going to notice if things changed or not, you will notice indeed that what changed was our experience with stimulation in antagonist protocol, and that indeed what was of the past should stay in the past, and what is of the present is the use of antagonist cycles. And just to prove an example of that, I'm showing you the results of the last antagonist versus agonist trial, where you see that for the first time, when it comes to cumulative live birth rates, the diamond seems to actually be inverting. And although it's not statistically significant, for the first time, cumulative live birth rate seems to be better in the antagonist cycle when compared to the agonist cycle. So please, the first thing you should be doing if you are worried about safety in your high performing patients and your hyper responder patients is to perform antagonist treatment always, 100% of the cases. Not only because it reduces OHSS in half already, but then second and most importantly, because it gives you the option to trigger with an agonist. This all without affecting live birth rates and reducing the burden of the patient. What we would like to discuss from now on is what can we do to reduce the risks even further. And agonist triggering is the one that comes to mind and the one that is discussed most. And it's basically because it works in a completely different way. In one sense, with the ACG trigger, which we usually do, it works by acting similarly to LH. Meanwhile, the agonist trigger in an antagonist cycle causes just a temporary displacement. And actually what it does is a short luteotropic effect, which is eliminated much faster. So if we would like to show this in a graph, we would use first a graph comparing what happens in day-to-day practice or in a physiological state in which LH will be in its peak for around 48 hours. In an agonist trigger, this peak is much shorter, and after a day, it's gone. Meanwhile, in an ACG trigger, things stay much longer, and this luteotropic effect, this ACG LH similar effect goes on for around a week. And that is the main reason why using the agonist trigger is so much better when it comes to safety, because ACG, which is our prime driver for OHSS, is eliminated from the equation. And when you look at the meta-analyses here, what you're going to notice is that the segmentation or the use of agonist triggering has a whole lot of zeros when you try to compare the potential for developing OHSS. And it's nice also to see that the RCTs agree with the observational studies. And overall, with over 2,000 patients studied in over 30 studies, you will only see 7 cases of early onset OHSS as individual reports when you look at all these reports together. There is a problem, however, is that agonist triggering makes your life more difficult when it comes to pregnancy rates. So this balance that you want between efficiency and safety, well, it seems like using agonist triggering and performing a transfer immediately after puts you in a trouble when it comes to this efficiency part. The pregnancy rates seem to be lower. So what can we do with this information? We know patients want to be pregnant and that they value that. And we know that they value safety at the same time. And also they want to get pregnant whenever possible, as fast as possible. So with this presentation, I would like to show you a little bit of what you can do after agonist triggering, and also present you a little bit about the results of the ICE trial, which was an RCT we did comparing 2 of these strategies head to head. Well, the first prospect, which is something that was actually the most classical approach, was to presume that what we do in menopausal women, which is just giving high doses of hormones, could be mimicked and replicated in an artificial cycle or in a stimulated cycle in PCOS women. So what many people coin the American approach, which is using very high doses of estradiol and high doses of progesterone in the luteal phase, could somewhat compensate for the luteal phase defect agonist triggering causes, and that we could maybe make things work in that sense. And the RCT that was used, and I try to present the results in the RCT because it's important for you to see how strong or not strong the data is. And what you notice in this RCT, which is frequently cited, is that actually you had less than 60 patients. So it's a very small study. And you were using the right population for OHSS. That's also important. You're using those which had PCOS or high response, but you were kind of comparing apples and oranges, because normally what you want with an RCT is to have the same modus operandi and just change one variable. But what you notice here is that in one arm, there was antagonist cycle, and in the other arm, there was an agonist cycle, which is completely different when it comes to causing the risk of OHSS to patients. And what you notice there immediately is indeed, there didn't seem to be a large difference in terms of ongoing pregnancy rates, but the moderate to severe OHSS rates were very, very different. So at first impression is that you might think, well, this is the way to go, and this is how we should be treating our patients. They seem to get pregnant as much as an agonist cycle, but the moderate to severe OHSS seem to have disappeared. Well, when you look more into the details and more studies that come after, and you notice that the Engman study is over here, well, kind of when you collect all these studies together and try to compare in reality, if ongoing pregnancy with this aggressive luteal phase support of high E2 and high progesterone values, does it work? Well, actually, it doesn't seem to be as great as performing another strategy, namely either Freezole or ACG by itself. So it doesn't seem to be actually giving you comparable pregnancy rates when you collate all the studies all together. So this might not be the solution. Another presented solution was using dual triggering. So using a smaller dose of ACG and using agonist triggering, and you were trying to compensate what you are missing in terms of ACG activity with a smaller bolus. And this study was actually a retrospective study, which is frequently cited, using the dual trigger approach in OHSS high-risk women. So it was the correct population. And it was interesting because although being a retrospective study, it was a more clear-cut study. There was one question and one answer, and there was only one change amongst the study groups. What you will notice, however, is that it's a very small study. So you were unable to be able to adequately see if there were a huge difference in terms of OHSS or not. There was a better live birth rate with dual triggering, which does show you there is a benefit by using ACG activity in those with hyper-response. However, with even such a small sample, you immediately saw that even with a small dose of ACG, you got a rather significant increase of OHSS in just 30 patients with severe OHSS, mind you. And then comes the most common approach, and the one that is mostly being used, which is the Eumydin approach, attempting to compare the use of a small bolus of ACG just after pickup versus not using agonist triggering at all and using ACG. And this was a very interesting trial because it was very ambitious. It was using this approach in women that were even at low risk of OHSS. And this is important to mention because it means that you have a lower likelihood to find OHSS to start with, because it were women that were at low risk to start with. And when you look at the study from Eumydin and all, the first thing you're going to notice is that they mention a non-significant difference in terms of ongoing pregnancy rates. And I leave it up to you to say, if you consider that going from not 26 to 33, whether that's although being non-clinically, not statistically significant, if it wouldn't be clinically relevant and worthy of having more information and having a larger study comparing. And moreover, what they did notice is in this low risk population for OHSS almost never existed in both arms, but the conclusion was, well, actually it only existed in the ACG group. So this is also a little bit calling to the interpretation of how things work. Alternative 2 is to do Freezole, which many centers are doing. And this was the kind of the most of evidence that existed at the time in the high responder papers when we started to think of producing our RCT. And at that time, when we started to produce it, we had an issue because the only study showing superiority was actually later retracted. And the other study did show a potential benefit, but it was rather small. So we didn't have a lot of information to go on. Then afterwards, and our study was already being conducted, but we were halfway through. It was interesting to see that Chen in New England, with a very large sample, was showing, oh, well, this is a huge increase of 7% of pregnancy rates in this population. However, there seemed to be what we call a regression to the mean. It wasn't as astounding as this 15% Shapiro saw. And also, there was an issue with Chen's paper, is that he still used ACG in this fresh population. So you couldn't really make it comparable in this high-risk population because nobody is using ACG anymore in this high-risk population. There was also a trial at that time coming from Humiden as well in women with more than 14 follicles, comparing ACG triggering and agonist triggering with this ACG bolus. But the problem with this study is that more than 14 follicles still includes a huge amount of patients which are still at relatively low risk of OHSS. So it was unlikely that you would be finding any huge difference in OHSS. So we decided to try and check the ICE trial. And our objective was to see if there were comparable clinical pregnancy rates in those which are very high risk of having OHSS. And these are the patients we were worried about, those with more than 18 follicles or more than 11 millimeters on the day of triggering. Well, our secondary objectives were live birth, and we were very interested in knowing to see if safety was there and met in terms of the incidence of moderate to severe OHSS according to the Golem criteria. And as you will see, our study is fairly clear-cut. The objective was to compare the so-called Humiden protocol, which was using agonist triggering, followed by 1,500 units of ACG, versus the use of artificial cycle in the freeze-all strategy. And what we estimated at the time, and if you remember, I was telling you that there was a study showing from Shapiro showing a 55% increase of clinical pregnancy rates. So we used that estimates according to our usual data, and we were estimating that we're going to have a nice increase of up to 15%. This meant that we needed 2,012 patients. It was a study that took a while to be able to recruit these patients. Fortunately, we can't use COVID as an excuse there. The things were a little bit slower to be able to have these patients with such high response. And then we tried to compare these. There were obviously some patients that needed to be excluded at the time. And the immediately thing you will notice is those that were in fresh transfer actually ended up not doing a fresh transfer to start with because they already had, after the ACG approach, some complaints of moderate to severe OHSS, or they actually asked not to perform it due to complaints that they personally perceived after. So immediately when you look at our study flow chart, you will notice that as usual, there are always some patients dropping because they withdraw consent. There is also a patient that has dropped because she conceived spontaneously after freeze-all. But generally, there were more people that didn't receive the fresh transfer because they were unable to do it due to either mild or moderate to severe OHSS complaints. Looking at our comparability of our outcomes, you will see that the samples, as expected in RCT, were relatively comparable, and that our day 3 transfers were also comparable, so that almost all transfers were done at the blastocyst stage. When it comes to the clinical results, the pregnancy outcomes did seem at first to be rather better in the freeze-all group, but then later on, when you start to account for the pregnancy losses, they seem at the end to be very comparable between the so-called Humiden approach and freeze-all. What was interesting for us, however, when we looked at the secondary outcomes, so to see if there were biochemical losses and ectopic pregnancy, those there weren't a large difference, but into moderates and to severe OHSS, things were in a completely different story. In fact, OHSS exclusively happened in those that tried a fresh embryo transfer, and it was 9% of our high-risk population that experienced moderate to severe OHSS. And was there benefits in terms of time to pregnancy for these patients? Well, that is the question you can see in these two graphs. Indeed, those that did a fresh embryo transfer did get pregnant on average 1 month sooner than those that did a freeze-all approach. And you see that in the beginning of this graph, where the increase is much faster. But cumulatively, however, the cumulative live birth rates were exactly the same. And the graph afterwards just follows exactly the same sequence. So in our view, in terms of cumulative live birth rates and time to pregnancy, 1 month and the same cumulative live birth pregnancy doesn't seem to be a huge difference. In these last final moments, I would like to speak to you about the clinical relevance of this study. It was actually the first one to compare head to head these two so-called safest approaches for hyperresponders in real hyperresponders, in women with really a lot of eggs. And it does show that you can have consistently good pregnancy rates. However, freeze-all seems to be more unsafe. There is one limitation that you need to know and that we can't forget is that at the time that we designed the trial, the evidence known by then is that it seemed that freeze-all was going to be much better. And we designed that thinking that live birth would be much better in the freeze-all approach. We didn't notice that in our study, and it seemed like we might have overestimated how much better performing freeze-all was going to be. So mind that, please, that there could be a limitation of a power to detect the difference in terms of pregnancy rates. So we come back to potential alternatives to patients that want to transfer a fresh embryo. And the ones that are being presented back and forth, especially after our trial, is, again, thinking about the American approach, which we believe it might be a little bit too early to come back to because of the data showing that it could be inferior. And there is, however, another approach that is being collectively talked about now, which is personalized luteal phase support or luteal coasting. And what this entails is the possibility of you measuring progesterone throughout the cycle and trying to decide when is the ideal time to give very small doses of ACG to patients in which progesterone is not increasing as much as you would like. For me, this seems super interesting, but there is still much more data that needs to come out before you can apply it. And my question is, won't this make your life so much more complicated? I would argue that yes. So coming back to freeze-all, and in the last 5 minutes to kind of speak about it, we do know that it's been increasing a lot in the day-to-day. And the only concern that I would have is that people tend to believe that this is the best and only approach existent, and that from now on, you can go completely crazy on ovarian stimulation and give 300 units to all your patients. When it comes to that, I would like to call to your attention that although the first reported case of severe HSS after agonist triggering was really criticized and thought as a one-time thing, well, since then, there have been more cases being published, and it's not any more reasonable to say that it can't happen to you. And one of the things that were then raised is, well, these are just genetic freaks that we're not going to encounter in our day-to-day practice. Well, we tried to check that, and we actually published 2 studies looking at a series of women that had OHSS after agonist triggering. And although we did find a small potential genetic disorder in the VEGF receptor, at all, we cannot say that this is universally caused by being genetic freaks. So I would still recommend that you be calm and that you don't go crazy on ovarian stimulation. We do know, however, that a lot of things have progressed since the 1980s, where FETs was something that you did very seldomly. And now that people are even discussing the possibility of freeze for all, they are discussing it because there is more evidence now pointing not only to the safety aspects, but also potentially to the better neonatal outcomes. And when you look at the data from SARTS, it's really interesting to see that the fresh embryo transfer outcomes have remained rather stable, while the frozen embryo transfer outcomes continue to increase. Is this because we're doing more PGTA? Is this because we're now using vitrification? We really don't know. But what we do know is that there are some studies pointing into the benefits to freeze-all, which are leading people to think that freeze-for-all might be the solution for all. There are others that are proposing that it might give you less ectopic pregnancies. Well, in the data that we published using UK data, that didn't seem to be the case. And in the registry data from the US as well, it does seem to be a case, but it's very difficult to explain what happened between 2003 and 2004 for all of a sudden ectopic pregnancy to become a much frequency in frozen embryo transfer. So I would say that this question is still in debate. There are other consistent benefits that people speak about when they try to toot the use of systematic freeze-all, which is lower prematurity and lower small for the gestational age outcomes. But there are others that are less consistent, which I would recommend you not to say that are always there. When there are chinks in the armor and things that, however, we would like to discuss, for the last 5 minutes of my presentation, those I would like to talk to you about. And those are about the potential risks of using freeze-all in all your patients. So extrapolating this from the high responder population. Well, the first that are normally spoken about are macrosomia and the pregnancy-related hypertensive disorders. But delay in pregnancy is something that was frequently approached in our study even, and also the potentiality that you can abuse the use of freeze-all. When we look first at birth weights, it's undeniable that the amount of studies that exist show that there seem to be more heavy babies in those that perform frozen embryo transfers. And the concern there is not that the baby is 100 grams heavier, it's actually that this might be causing more diabetes and cardiovascular disease after. What I ask is this actually because the embryo was frozen, or is this a problem of you actually having more light babies in the fresh embryo transfer? And well, when you look at studies comparing in the autologous model, stimulated IVF and natural cycle IVF, you will notice, for instance, that preterm delivery and low birth weight is much less common in natural cycle IVF. And then when you turn to the donor recipient model, you will also notice that low birth weights and very preterm delivery are comparable in the oocyte donation model, which means that in those in which you don't stimulate the endometrium, it doesn't seem like there is a problem to freeze your embryo. This is exactly the same outcome we presented last year in ASRM using a much larger sample of over 5,000 oocyte donation cycles, showing exactly the same outcome, which is it doesn't seem to be a problem to freeze your eggs or your embryos when it comes to birth weights and prematurity. And it also doesn't seem to be a problem regarding other disorders like hypertension, diabetes, and C-section rates. When we come to hypertensive disorders, the question comes again. Is it because you froze your embryo, or is it because of the type of embryo transfer you did? And here you will see that 3 studies coming from all over the world show that it seems to be a problem of the type of transfer you do. And that if you're doing more artificial cycles, then it could be a problem for hypertensive disorders at the end. For those that are now battling with this evidence, because we know that it's out, one of the things that frequently come is, I don't have the time, nor do I work on weekends to be able to perform so many natural cycles. And there I would argue, if you have the possibility in your natural cycle patients, one thing you could consider are modified natural cycles. That means giving ACG when the dominant follicle has arrived. This will really make your life much more easier when it comes to programming. It will help you avoid many of weekend transfers, and it will also reduce by 1 the number of clinical visits that you will have. Coming to the other question is, doing freeze-all give you a delay? Well, we showed you our results, but one of the other concerns that we have is that frequently patients after a hyper-response in freeze-all are asked to wait a couple of months before performing their transfer. And I'd like to show you our first results in 2016, comparing the possibility of doing a fresh an immediate transfer taking advantage of the fact that in freeze-all you menstruate 5 to 7 days versus waiting 1 or 2 months more. And we did this study connecting two groups. First, the group from Brussels and then the group from Vietnam, because not a lot of people were doing immediate transfers at the time. And this study, which was very difficult to understand, actually showed us that if anything, there was a benefit of transforming or transferring your embryo immediately. We really didn't know how to justify these results. And you can see that in the discussion when we published the paper. However, soon to be published is an RCT that showed exactly the same thing. When you did an immediate frozen embryo transfer or a delayed frozen embryo transfer, you had a significant increase of pregnancy rates in the immediate fed sample. So yes, you will have a small delay performing freeze-all, but please don't delay more. There is no benefit whatsoever to allow the body to recover. Finally, discussing on the potential abuse of freeze-all, I would like to remind you that there isn't a lot of evidence of its benefits in normal responders. There isn't a lot of benefit known for poor responders. In those that use it for RIF patients, reminding you that the study that showed this benefit is still of limited value and needs to be confirmed. It doesn't have a large sample and it wasn't randomized. And that for a end, in terms of progesterone, levels between 1.5 and 2, which were the most touted ones as being cost effective, well, maybe with most recent data, and this using more recent methods, which you might not even notice that your progesterone levels have gone lower because you have changed the assays that you're using. Well, I would warn you to please recheck your assays like we've done in EV as well, because you will notice that maybe 1.5 is no longer the number and you need to go a little bit lower when performing a decision to perform fresh embryo transfers. So at the end, it doesn't seem that there are so many kinks in the armor of freeze-all, although it is too soon to go freeze for all. So my take-home message would be that in my view, probably it's not a good idea to save cycles in the hyper-response patients. And I will be looking forward to your discussion in the next couple of minutes.
Samuel, hi. Thank you. I mean, first of all, thank you for abiding the time and thank you for the extensive coverage, with all aspects. And so even though the other lecture is relevant, still just to give people some time, let's take a few questions. So I see Professor Mercan, it's a pleasure, please. I'm taking a few questions for you. Ramazan abi, mikrofonu da açarsanız. Abi mikrofon kapalı. Hala kapalı. Hala kapalı. Abi kapalı yaklaşınca çıkmıyor ses. Peki Ramazan abi mikrofonunu açmaya çalışırken any other questions? Kimseden başka bir soru var mı Samuel'e? So he is not able to turn on his mic. It's because of the desktop in the office, I believe. Okay. And let's see if there are any other questions. Listen, I really enjoyed the last part too about the immediate transfer issue. Let me do the presentation, then it should be one of the subjects that we should dwell into. I've been doing the same for 4 or 5 years after your first paper. Recently analyzed our data, and it's consistently better. Yep, and I suspect that it behaves like a fresh transfer in some aspects. Bülent abi, can you make Professor Mercan a co-host? I mean, he's not allowed to talk. You're oppressing him.
No, I'm not doing that actually. Just let huh? Well, I can't unmute his microphone. I can only ask him to unmute it.
There we go.
Şimdi oldu.
Evet, evet.
Abi engelledin ama buraya kadar oldu.
Mazlumların sesi çıktı diyorsunuz.
Tamam. Mazlumların şeyi oldu. Şimdi Barış, soru bir Türkçe soracağım ama tabii soru sormayacağım açıkçası. Yani Frizol'un hiperstimülasyondaki rolü
Sen
tartışılmaz.
görünmüyorsun. Kameranı ayarla.
Ya kameramı da ayarladım. Tamam. Yakışıklı.
Durduramazsınız beni.
Şimdi daha tane tane açıklayayım. Fizyopatoloji ile ilgili bir takım kaygılarım var. Onları soracağım. Daha önce de tartışmıştık aslında. Az çok biliyorsun. Bir, yani Frizol'un hiperstimülasyonu engelleyici rolü konusu tartışmasız. Yani onun için hiperresponderlarda bu konu tartışmasız. Ama olayı Box-Tree hipotezine kadar götürüp biraz felsefikleştirmek bana çok mantıklı gelmiyor. Çünkü açıkçası biz IVF'de düşük doğum ağırlığından bahsederken ne IUGR'dan söz ediyoruz, SGA'dan bile söz ediyor muyuz? O bile tartışmalı açıkçası. Çünkü tamamen sadece ortalamaların 3100'lerde olduğu bir klinik durumdan bahsediyoruz. Yani bunu klinik olarak Box-Tree hipotezi, adult life'daki bir takım hastalıklar gibi yerlere kadar götürmek oldukça zor. Bunu plasental patolojiyi, plasentasyon patolojisi olarak değerlendirmek de zor. Çünkü plasentasyon patolojisi olabilmesi için bunun gerçekten hakikaten IUGR'la sonuçlanması gerekiyor. Yani şöyle, presentasyon patoloji IUGR'la ilgilidir ve erken IUGR presentasyonla ilgilidir. Geç IUGR'ın bile presentasyonla bir ilgisi var mı yok mu henüz tartışmalı. O konu bile net bilinmiyor. Presentasyon mu geç IUGR'dan sorumlu, yoksa bir takım epigenetik mekanizmalar mı sorumlu, yoksa daha bilinmeyen birçok faktörler mi sorumlu? Yani onun için ben olayı presentasyona kadar götürüp bunun adult life'a etkisinin olabileceğini, yani klinik önemi çok da fazla olmayan bir durum gibi algılıyorum aslında o 3100'lük ağırlık ortalamalarının, ki eğer plasentasyon patolojisi olsaydı gerçekten bu hastalarda erken dönemde bir IUGR görmemiz lazımdı ki böyle bir klinik durum kesinlikle yok. Artı bu hastalarda hipertansiyonda da yüksek oranın da yüksek olması gerekirdi. Çünkü erken IUGR olgularının neredeyse yarısında zaten preeklamsi görüyoruz. Bizde preeklampside tam tersine normal fresh cycle'larda Frozen'la karşılaştırdığı zaman bir azalma bile var. Bir de slide'ı yanlış mı okudum bilmiyorum ama preterm oranları %30-40 gibi oranlar orada telaffuz edildi. İşte normal natural cycle IVF'de %30, normal klasik IVF'de %40'lık bir oran gördüm ama yanlış mı gördüm bilmiyorum ama bu oranlar da bana çok mantıklı ve akılcı gelmedi açıkçası. Yani sonuç olarak diyorum ki bunu presentasyon patolojisine bağlamak çok doğru değil. Çünkü fizyopatolojiye hiç uymuyor. Perinatologlar orada, onlar da beni destekleyebilirler mi bilmiyorum. Ya da en azından tersini söyleyebilirler mi? O da çok iyi olur. İkincisi Box-Tree hipotezi falan filan burada zaten söz konusu olamaz. Eğer ortada bir IUGR yoksa, ortada bir gerçekten makrozonu yoksa, Frozen tarafında da söyleyeyim, sonuçta bu Box-Tree hipotezi ileriki adult life konusunda bir kaygıya yer olduğunu hiç düşünmüyorum. Teşekkür ederim.
Şimdi ben bunları iki cümleye, hadi iki yapamayacağım da üçe indirip bir Samuel'a sormayı deneyeceğim.
Geçen gün ben bir laf ettim. Sen sporcu tercümesi gibi 2 saat tercüme etti. Şimdi bakalım 2 lafa nasıl indireceğim göreceğim.
Önümüzdeki maçlara bakacağız. Yes.
Maybe I can ask a question and we can
combine the two.
Yeah,
sure, why not?
Maybe Samuel can answer both questions.
Sure.
And
okay.
There's this recent data that was published on PGTA cycles that showed a a mild association with hypertension, hypertensive disorders of pregnancy. And there was also a comment on that paper in FNS in the most recent issue, from tension to hypertension. So especially in the issue of freeze-all, I don't know how many freeze-all cycles that have been evaluated within this context are actually PGS cycles. And some of the observed differences in perinatal outcomes in these cycles, can they be due to the fact that this embryo was biopsied before transfer?
Yeah. So it's a very interesting question to see can we further understand why patients that are doing frozen embryo transfer cycles have more hypertensive disorders? And while I do believe that the lack of a luteal corpus luteum is one of the potential reasons, I don't believe it's the only reason. There is another reason that can be concerned, which are embryo-related factors. So indeed, causing stress to the embryo can impede its implantation. And that is the theory that was advanced by this recent paper. I believe that it was deserving of a commentary because FNS is performing more and more commentaries. I still think the data is, however, very preliminary to say so forth. What I can tell you, when we look at oocyte donation cycles, is that these again tend to be more in artificial cycles, and that oocyte donation cycles tend to have higher preeclampsia levels. And when you look at the results we presented last year in ASRM, which we hope will be published in human reproduction, you notice that baseline preeclampsia levels are higher, but they are comparable between natural and artificial cycles. Finally, another issue which I believe is really important to discuss as well is the fact that PCOS by itself doubles the risk of hypertension in pregnancy, and you will do artificial cycles more frequently in patients that have PCOS, and those you will more frequently also be inclined to do PGTA. So what I believe is there's a lot of confounding, and there are a lot of drivers that make you perform more preeclampsia risk things in high-risk preeclampsia people. Yeah. So I think that message is still up to debate.
Yeah, thank you. So maybe Barış can summarize what Dr. Mercan has asked.
I've been preparing for the last 5 minutes for that. Samuel, what Professor Mercan was saying is, there's no doubt that canceling the fresh transfer and freezing all embryos is beneficial with regard to prevention of OHSS. However, he says that, he's not convinced that, freezing all embryos and going for a frozen transfer should be done for preventing, other obstetric complications like preterm delivery or small for gestational age, because the data regarding the association of fresh transfers with small for gestational age or being born at small weight percentiles is not conclusive, and it's open for debate as well. So that's in a nutshell, and which I would agree, because in the updated data, what the relative risk of being small for gestational age after a fresh embryo transfer as opposed to spontaneous pregnancy is like 1.15, 1.2, so it's far from conclusive. Yeah, on average, the babies are slightly smaller, but yeah, probably not. So how would you think?
I can't disagree. I would completely agree. I think that most of the focus that I said was that, and that's my major concern, is that people, in some sense, are avoiding freeze-all because it gives you heavier babies. And the point I was trying to make is, well, no, what they are just less lighter. And it's unlikely that you're going to have more diabetes because of that. And actually, there is some interesting data comparing this theory of more diabetes in these children and more abnormality, and it's not being shown. So it's just, in my view, fear-mongering, and you might be avoiding inexistent late-term problems and ignoring your immediate problem in putting your patient in the intensive care unit.
Yeah, exactly.
Yeah.
So any other questions for now, or should I make the presentation and then we should have a broader discussion? I don't see any hands raised. Okay, let me see if I'm allowed to share my screen. I think I am. Yeah, share. Yeah. All right. Samuel, I'll do this in Turkish for the sake of the audience, but it's It's what's in the commentary, okay? And I'll tell them the story of the commentary as well. And I'll tell you that in discussion too. Şimdi bu Samuel'ların bu sunduğu çalışma uzun yıllar sürüp işte sonunda bu eğer küçük doz ECG verip taze transfer yaparsanız bile %9 OASS yapıyor diye yayınlandı. O esnada ben bu makalenin yani az confidential sayılmaz artık yayınlandı. Hakemlerinden birisiydim ve hakemlerin arasında yazının bazı yönleri istatistik hakemleri falan tam kavramadıkları için konuyu böyle uzunca tartışıldı. Gitti geldi. En sonunda hani düşündüm ki bunun bir önemli mesajı yeterince dikkat çekmeyebilir. O nedenle hani bu işte editors highlight, commentary falan bir şeyle yayınlanabilir. Ve hani onu to put in perspective böyle bir yazı istediler o tartışma sırasında. Özetlediğim şey şu, burada Ramazan dediği yerle çok girmeden Samuel çalışmayı anlattı zaten. Olmayan bir şeydi. Hyper responder'larda küçük doz ECG artı taze transferin analog trigger'dan sonra analog trigger artı freeze all'la donmuş transferden sonraki hem güvenlik hem verimliliğini karşılaştırıyordu. Bakarsanız hastalar 30 yaşında gibiydi. Güzel yanı bu çalışmanın %86-87'si tek embriyo transferi ve %90'ından fazla blast transferiydi. Yani günlük uygulamayı yansıttığı için genellenebilirliği yüksek bir çalışma. Ve canlı doğum oranları kendisi söylüyor aslında freeze-all'da belki eski verilerle daha yüksek olmasını beklerken hani en azından daha düşük çıkmadı ama önemli yeri burada %9 OASS gösterdiler. Aynı gibi OASS bir çocuk sahibi olmak dışında, güçlük çekmek dışında sağlık problemi olmayan, sağlıklı ve genç üreme çağındaki bir kadını potansiyel olarak öldürebilecek bir komplikasyon. Öldürmese bile bir tromboembolik başka komplikasyonla sekel de bırakabilir ya da en azından ciddi bir süre hayat kalitesini ya da gebeliğin seyrini etkileyebilir. O yüzden hani ne olursa olsun engellemeye çalışmak mantıklı. Nasıl oluyor? Çok folikül gelişip çok granüloz hücresi olunca HCG'nin uzun süreli uyarısı bunların hepsini luteinize edince çok vasküler endotelyal growth faktör endotel hücrelerindeki reseptörüne bağlanınca kontraksiyon ve kapiller permeabilite geçişi böyle bozuluyor. Bizim amacımız evet etkinliği korumaya çalışıyoruz ama insanı riske atmak için kabul edilebilecek hiçbir şey yok. O zaman bunu önlemek lazım. Önlemenin de yollarından birisi bu uzun süreli luteinizan uyarıyı ortadan kaldırmak. Bir tanesi bu korpus luteumları direkt ortadan kaldırmak ya da bu kadar çok olmasını sağlamak ya da şu VEGF'lerin reseptör düzeyinde etki göstermesini engellemek. Analog trigger'da bu mantıkla çıkmıştı. Yani HCG yerine verince bu kısa etkili analog bu uzun süreli luteinizan etkiyi yapmadığı için VEGF düzeyleri daha düşük kalıyor. Korpus luteum atreziye gidiyor. Hani yumurtaları siz topluyorsunuz ve siklüsü iptal etmek zorunda kalmıyorsunuz. Yani 15 sene önce aşırı yanıt olduğunda bu bilinmediğinde bazen HCG yapmaktan çekinildiği için siklüs total iptal oluyor. O zaman daha yüksek kozondotropinler, daha pahalılar falan herkese stres oluyordu. Ama bu çıktıktan sonra bir şey görüldü ki bundan Samuel bahsetti. OASS riskini azaltmakla beraber bakarsanız gebelik oranında ve canlı doğum oranında bu analog trigger siz arkasından bu zayıflayan luteal fazını da kurtarmak için bir miktarcık ECG ekleseniz de evet kurtarıyordunuz ama hiçbir zaman tam yakalamıyordu. Yani bu çalışmanın orijinal rakamları biraz yanlıştı. Düzeltince bunları iyice sınıra geliyor. Ama hani tam da taze transferi HCG trigger'dan sonra tam dozda yapmış gibi olmuyordu ki bunlar düşük riskler. Güvenli olduğu için iddia edilirken bununla ilgili ilk arkasından OASS olduğunu o zaman biz yayınlamıştık. Bunun da hikayesi bu garip olarak takıntılı bir konuydu. Çok popüler olduğu için biz ilk bir vaka oldu gönderdik one case diye olmaz böyle şey bir şey yanlış yapmışsınızdır gibi falan diye bir şey gerekçe reddedildi. Ondan sonra ikinci oldu 2 tane diye gönderdik reddedildi. Sonra bir toplantıda Hakan abilerle konuşurken onların da oluyormuş diye bu sefer alıp hepsini topladık. 23 tane de 5 tane mi ne oldu? Ve hani tam bir güvenlik sağlamadığını da gösterdik. Bu yazı yayınlanana kadar 4 hakeme gitti. Editorial'lar, mektuplar falan Yani ikna olunması zaman aldı ama en nihayetinde hani bu güvenliği sağlamadığı artık hani bugün kabul ediliyor. Peki güvenliği korurken o zaman bunu kullanmayacaksak verimi nasıl yapacağız? Verimi nasıl koruyacağız? Bakın biz eskiden beri burada söylemeye çalıştığım şey şu. Analog trigger artı küçük doz HCG ya da işte daha değişen hesaplarla HCG falan vermenin güvenlik açısından anlamı olmadığını anlatmaya çalıştım. Verimlilik açısından da anlamı yok. Çünkü bakın bu meşhur HEPA verisi Şeş Kemal'in analiz ettiği yanıt arttıkça bir yerden sonra canlı doğum oranı taze transferle artmıyor. Belki bir miktar düşüyor gibi görünüyor yanıt arttıkça. Bu da daha recent yani EVRMA artı Avrupa'dan birkaç merkezin verisi. Burada da yine neredeyse 10 taneden sonra hatta bu etki görünüyor. Plato 15'ten sonra bakın şu açık renkler taze transfer başına canlı doğum oranı düşüyor görünüyor. Halbuki kümülatif sürekli artıyor. Yani siz yumurta sayısını azaltmaya çalışıp taze transfer yapacağım demeye gittikçe siklusun total verimi de azalıyor. O yüzden hani taze transfere ısrar etmenin bir anlamı yok gibi. Dondurarak bir şey kaybetmiyoruz. Eskiden vitrifikasyondan önce yine ben 15 yıl önceyi hatırlıyorum. Yani o plannerlarla her şey normal gidiyor görünse bile embriyolar çözüldüğünde canlılıkları sağlam görünse bile gebelik elde etmek zor oluyordu. Merkezler arası istikrar yoktu falan ama bugün vitrifikasyon verisine baktığınız zaman canlı doğum taze ya da donmuş embriyolar arasında genelde birinin lehine çıkmıyor. Ama hyper responder'lara doğru gittikçe bu olumsuz endokrin etkisi yüzünden endometrium üzerindeki donmuş transferlerin canlı doğum oranları istikrarlı olarak daha iyi gibi görünüyor. Yani verimlilik açısından da burada donmuşa gitmek lazım. Samuel'ların çalışmada kafa kafaya çıktı canlı doğum oranları ama başka bir çalışma bahsetti o da Wei, Lancet'ta yayınlandı. Çok benziyor bu çalışmaya. Nasıl çok benziyor? Bu daha büyük bir örneklem. Randomize kontrollü, yine çoğunluğu blast transferi, yine çoğunluğu tek embriyo transferi. Ve bakıldığında donmuş transferle taze transfer arasında donmuş transfer yönüne burada anlamlı bir fark var. Bu VOASS yine anlamlı olarak taze, donmuş transferde daha az hipertansiyon eğilimi görülüyor ama bunlar bir kısmı popülasyonlardaki farklılıklardan olabilir. Bir kısmı yanıtın düzeyindeki farklılıklardan olabilir. Bir kısmı random oynamalar olabilir. Ama agregat bakarsanız over yanıtının şiddeti arttıkça endometrium üzerindeki olumsuz etkiler artıyor gibi görünüyor ve hani taze transferin verimi düşüyor. O yüzden verimlilik açısından da hani ha bir embriyoyu verip siz 5 tane dondurmuşsunuz, ha 6 tane baştan dondurup o bir taneyi de daha sonra mümkünse de hatta doğal siklüste verirseniz önemli bir maliyet bile gelmiyor. Az önce söylediği gibi bunu da hemen arkasından yaparsanız zaman kaybı da sınırlı. Bu gözle bakarsanız verimlilik açısından da bunu yapmak gerekmediğine ikna olursanız o zaman hani hyper responder'lara ben analog trigger verirsem arkasından ne yapayım da taze transfer için luteal fazı kurtarayım demenin bir anlamı kalmıyor. Yani bu tartışmalar anlam sahibi. Aksine luteal fazı daha da çökertmek gerekiyor ki güvenlik amacınıza da ulaşın. Yani OASS engellemek için farklı mekanizmalarla çalışan birden fazla yol var. Bunu daha sonra TSRM guideline olarak da göstereceğim. Yani bir antagonist siklus kullan, agonist trigger yap, luteinizasyonu azalt. HCG'de vermeyerek. İki, VEGF'in etkisini azaltmak için eğer çok riskliyse hasta kabergolin kullanıp reseptör düzeyinde oluşan VEGF'in etkisini de azalt. Üstüne bir de endojen leasını daha da baskılamak için ne kaldıysa ondan birkaç günde GnRH antagonist verirseniz luteal fazı iyice crash olacağı için bu hastalarda OASS görme sıklığınız şahsen sıfıra yakın olur. Sıfır hiçbir zaman iddia edilemezse de ama ben hani az önce onu değil ben bazen hani çok şiddetli uyarmama rağmen yıllardır görmüyorum. Peki maliyet açısından problem mi? Demin söylediğim gibi taze verseydik de hani başka bir işe girişmeseydi bu hasta diye. Bir tane cost effectiveness analizi var. Belki Semihullah sonra bu çalışmanınkini de yaparlar. Orada bir bu grafiklere alışıksınız. Bir fark yok gibi görünüyor. Yani maliyet verim avantajı yok gibi görünüyor donmuş transferin. Ama bunun arkasındaki varsayımlar bu gördüğünüz çalışmaya dayanıyor. WOM'un. Bu da hani randomize kontrol bir çalışma. Taze mi donmuş mu transfer yapılmalı diye polikistik overlerde. Fakat bu çalışmada birkaç tane fark var. Toplanan yumurta sayısı ve over yanıtının düzeyi o kadar yüksek değil. Artı canlı doğumun avantajı donmuş transfer tarafına bir eğilim olmakla beraber %2,5. Hani bu kadar bu yanıt düzeyinde bile hani farklılığın sınırında. Fakat bu çalışmada yüksek OASS riskli görülen hastaları biz randomize etmedik diyorlar. Yani dolayısıyla tam olarak konuştuğumuz duruma genellenebilir bir şey değil. Ve hani yanıtın şiddeti arttıkça OASS riski ve endometriyel olumsuz etkili artacağını düşünürseniz hani başka bir popülasyonda daha yüksek yanıtın olduğu popülasyonda hem canlı doğum dengesi donmuşun lehine kayacaktır hem OASS dengesi donmuşun lehine kayacaktır. Cost effectiveness da muhtemelen kayabilir ama cost effectiveness kaysın kaymasın hani yani boş ver bir transfer işte ne bileyim bir miktar daha az para harcansın diye önlenebilecek bir komplikasyon hani riski alınır mı? Bence alınmaması gerekir. Bakın 2015'te bunu TSRM'den yayınlamıştık. Birden fazla yöntem var. Bunları kendinize göre farklı risk düzeylerinde farklılarını alabilirsiniz. Burada böyle kademeli artan bir şey vardı taze transferi korumaya yönelik. Ama bu hani donmuş transferin verimiyle ilgili bir kısım yazıdan bile önceydi. O yüzden hani şimdi daha leniently endişe ediliyorsa hem verimlilik hem güvenlik açısından donmuş transfere bence dönülebilir. Yani özetle çok yumurta varsa HCG ve taze transferle uğraşmayın ki bu çok yumurta kanaatimce 15 civarı bir yer. Ve donmuş transfere gitmekte herkes için hem güvenlik hem verimlilik açısından fayda olduğunu düşünüyorum deyip bitiriyorum. Yes. So it's what was in the commentary, okay? And just to put in perspective, so no point in pushing a fresh transfer, neither for safety nor for effectiveness. Okay, and I think it will be even cost effective. And I'm looking forward to your publication of the cost effectiveness data with your data. I mean,
we did ask for it, huh? We did ask for it, and we wanted out for sure. And the problem and the concern I have with cost effectiveness data is from where the standpoint you come from, right? And they, if your medication is reimbursed or not, if your vitrification is reimbursed or not, if you're public or private, this makes a whole huge difference. And that's what we're battling now. On a personal level, it's because we're using a Spanish cost effectiveness statistician to analyze a Belgian data. So it's it's a problem.
I mean, regardless of the like paying party, like third party or out of pocket, I mean, someone who has like 5 blastocysts, I mean, if you freeze one, I mean, transfer one, you still freeze the other 4. Okay, so if you're charging for a batch, if you don't transfer any and freeze the 5, it should be now like similarly effective. The only thing, would be the cost of towing actually for the first transfer and monitoring for the frozen cycle.
Yeah.
Which, you know,
for me,
having OHSS, I think still makes sense.
Yeah. For me, the most interesting part in what we're doing is called averaging out. So what we're using is European average data for the costs. But to be honest, for me, where I really think it would be really interesting is when you add in the indirect costs and the direct costs together, because I really think that that's where the money comes and becomes expensive. The OHSS patients, how many of them stayed inside for? Yeah, so one OHSS extra is going to cost you like 4 frozen embryo transfers for sure. And that's where I think things come really interesting. And patients do look at cost effectiveness. Governments do look at cost effectiveness, but I don't think that's the issue of wanting to do a transfer as quick as possible will disappear. I still think patients will want to transfer whenever possible their embryos. And it's up to us first of all, to not make it become a surprise. And that's something that I think we've all been working better at, is immediately at first consultation or second consultation, even when IVF is still being discussed, it needs to be part of the discussion. We're going to transfer one embryo and we're not going to do it now. It's unlikely. I think it's really important. This really changes patient satisfaction towards freeze-all.
No, exactly. I mean, if you inform the patient in advance about what are the possibilities, it's easier for them to understand and accept when the day comes. Listen, I want to switch to another subject. I think everyone is more or less convinced that nobody needs to push for a fresh transfer. I'm interested in your views on the immediate transfer. Okay, so I mean the majority of embryo transfers are frozen nowadays, and arbitrarily most people used to postpone it for at least one menstrual cycle or maybe two to start, and then it became a time-pressing issue, especially for older women. Okay, and after reading your paper a couple of years ago, and I started doing immediate transfers, and it's not a randomized trial. We've collected our data, and what we see is, I've done 2/3 of my frozen transfers like in the first immediate cycle, and the pregnancy rate seems to be higher, live birth. And obstetric data, what I noticed is more or less, I feel like it more resembles like a fresh transfer in one sense, okay, like weight and other stuff. So how do you think about it? I mean, do you think the endocrine environment after the stimulation cycle could still have an effect on the endometrium implantation process and the course of pregnancy in the immediate next cycle when you do a fresh transfer? Do you observe any differences in your obstetric data?
Yeah. So this is, for us, like I said, when we first published this paper out, for us it was very hard to explain, right? So when you're trying to not, and having a rationale is the first thing that you need to think of. So if you don't have a strong rationale, you just need to admit that your data may be weak, and that's when you perform adjustments, especially if you perform adjustments, if the effect disappears, you need to say that your data might be weak. So when we came out with our data, we said, in our view, well, this can only be maybe one thing, and it could be that the preceding accelerated luteal lysis can be positive for the next cycle. And there was some data looking on that information regarding the effect of the progesterone concentrations of a preceding cycle on the next cycle. And these are works coming from the group of Diamond that you guys will know. He works a lot on PCOS patients, and he's exceedingly interested in trying to see how you can optimize PCO outcomes. And one of the things that he's noticed is that you can actually get better pregnancy outcomes if patients aren't forced to menstruate and aren't forced to the luteal phase before. And so our theory was there. Is it a strong theory? Not really, right? It's something that you need to confirm, and it would be easy to confirm. You would just need to do agonist triggering before any frozen embryo transfer and see if it makes your life work, right? I don't think people will do it in a clinical practice. It could be interesting to check after. We presented that theory as an hypothesis. The Chinese group that did the RCT believes it has to do with stress. They believe that you may be less stressed when you do it like that. And now you have, I think last week, a meta-analysis on that topic coming from the group of Anja Piedenborg. And then they again come to the possibility of stress and also to the possibility of the duration of cryopreservation. And there you have a Chinese trial showing that indeed, if your embryos are cryopreserved for a very long time, it could be an issue. And I think that might be something that you can also visit to. I can't justify the reason. What I can tell you is that it's consistently there. And it's also only there in the patients that perform agonist triggering. If you look at the latest data, and if you look at the sub-analyses from the RCT, The ACG triggered cycles don't have this. And that's also super interesting.
Evet. Yes. Soru, yorum, katkı, yani anladığım kadarıyla zaten hani çok
bir şey sorabilir miyim?
response'da takip etmezsen. Tabii abi, buyurun. Please.
Bu senin immediate transferlerinde maybe I should ask in English so
yes, Samuel can respond to.
So answer the question. Regarding the immediate transfer of frozen embryos, immediate transfer meaning in the upcoming cycle without waiting for another month. You said that you actually had higher pregnancy rates. What was the control group? So that is one of my that's one of my questions. And obviously, if you are doing the transfer in the immediate next cycle, you are not down regulating the patient, meaning that you're not giving any GnRH analogs. So can or might some of the differences that you have observed be due to, let's say, selection of a non-down regulated or a natural cycle when you do the immediate transfer, as opposed to a down regulated cycle when you do a deferred frozen embryo transfer?
Samuel, would you like to answer first?
Yeah, if that would be okay. For me, it's a lot of interesting data there. So that was one of the possibilities. Actually, there's one study that did that. So that what they did is they continued to give agonist triggering after freeze-all, and they compared the rates of immediate transfer with those that did downregulation versus those that don't. The study that we had, there was no downregulation in both instances. So the study group was immediate HRT, artificial cycle, after freeze-all versus deferred HRT, again, with no agonist downregulation. So it was either that immediate cycle or 1 or 2 months or later, another cycle later. We didn't use a time-based definition. We used a menstruation-based definition. So immediate menstruation or 1 or 2 cycles. Our study was only in HRT cycles, and the concerns is that this could maybe not be replicable in natural cycles. If you look at this year's first edition of Fertility and Sterility, you will see that there is no problem whatsoever with natural cycles as well. And again, in natural cycles, there's no downregulation whatsoever, right? So that makes it even more comforting to know that in whatever way you choose to do a natural cycle, it's going to work. Or the frozen cycle, it's going to work. And this is, again, also in the sub-analyses of the RCT, that regardless of the type of cycle you do, it works. And I can tell you now, there is just one issue. If you have many, many eggs, when you're doing this first ultrasound for a natural cycle, you can have a difficulty in determining which is the dominant follicle. Is it there? That can make your life a little bit more difficult. So if you want to do a natural cycle, be aware of that.
Yeah. And Samuel, just before Barış makes a comment on the same subject, I would like to ask whether you think there's a difference if you do a natural cycle, meaning a natural cycle all the way through with an endogenous LH surge, or a modified natural cycle whereby you give HCG after the dominant follicle reaches a certain diameter.
So I believe that I am part of the people to blame to make us originally believe that LH was better. We even have a paper by Montagu and all, she's the first author, saying, actually, we looked at each drug that you add. If you added ACG plus progesterone, worst case scenario. If you just added progesterone and not that bad, but still bad, and then the natural cycle was the best. Fatemi is still on that line. I have ever since changed my view. I believe that the study by Shahri Makens, which was published last year, which I presented during this presentation, gives us tranquil information to say that ACG will make your life easier and it's not going to reduce your pregnancy rates. I believe that the retrospective studies, because that's what you had, retrospective studies mostly, show different results because there is an inclination to do more natural cycles, completely natural cycles in patients of better prognosis. And you would argue that, yes, you can fix that by statistical approaches such as regression. Well, regression can only do so much. So I think we are part of the group of people that pointed to that possibility, always trying to be cautious of the results, but pointing to that possibility. And I no longer share that opinion. I believe that there is no benefit. And most importantly, I'm very worried that if you push too much the natural cycle, it becomes too impractical and physicians won't do it just because it's unpractical. And there's so many other advantages with the reduction of miscarriage rates and the reduction of hypertension that I don't want to make physicians' lives difficult. I would go for ACG.
Thank you. Barış, sen o soruyla ilgili bir şey yorum yapacak mısın?
What I do, ben anlatabilirim. Bizimkinde so was you analyzed, it's almost ready for publication. 120 immediate transfers. I mean, very little numbers as opposed to Chinese, but anyways, it's our own data to make a decision for ourselves. And 80 delayed transfers. So we broke them down as like 30 days. I mean, it's the immediate first menstrual period. Then you end up, I mean, you always end up in 30 days, okay? Yeah. And in any other menstrual cycle. So the median day of transfer was 26 days after egg collection in the immediate group and 76 days in the delayed group. So it's like, a month or 2 months, okay? So what I do is similarly, I mean, as those freeze-hold cycles, so we only included freeze-holds, are usually hyper-responders or elevated progesterone or PGT anyways. So they're not necessarily poor responders, right? So they're not the candidates for PGT. They're not, like candidates for OHSS. So there are usually many corporal lutea, and it's difficult to observe the dominant follicle. That's one reason. So I do an artificial cycle for these women as well, unless they have an underlying high risk of hypertension or diabetes, like such stuff. But the other thing is that I observe is even for women who has, like regular 28-day cycles, or that's what they've been telling us, okay? When I tried to do a natural cycle transfer in the immediate cycle after a collection, some of them did not grow a dominant follicle in 14, 15 days, and they didn't even menstruate in 28, 30 days. So their ovulation was delayed. So if I'm doing immediate transfer, I'm always doing artificial cycle now. And yeah, like consistently with literature, the pregnancy rates are higher. Otherwise, I'm doing all my frozen transfers in modified natural cycles. I don't think it's harmful. And and that's what the data suggests as well, and it makes life easier for everyone.
Yeah.
Thank you.
And if you want to do an artificial cycle, I don't think you should be worried about the risk of hypertension so much unless there's an underlying risk, because yes, it's statistically significantly higher, but the absolute numbers are still small.
So do you give any progesterone if you do a natural cycle, or is it completely natural? I mean, despite the fact that you're giving HCG or going for a completely natural late stage.
So the thing is, to be entirely honest with you, we have a big team with a lot of transfers. So this was a decision of debates. I would argue that progesterone kind of gets a little bit in the way for you to sometimes be 100% sure that ovulation occurred. So basically, the reason why I'm mentioning that is that sometimes we catch our patients late and we catch them with an immediate ovulation in which we're not going to give ACG, or we even catch them 2 days later. And then, in my view, to give progesterone, it might be risky because you can't follow up the cycle and understand if progesterone really is being well secreted, okay? But the decision amongst our group, taking the pros and the cons, was to give systematically progesterone. I would argue that it could be a good idea. We're going to be presenting you some interesting data in ASRM, which I hope you will all be able to see and that will be approved in a strategy that we call the modified artificial cycle. And that will kind of change the way you think of artificial cycles and natural cycles, in which what we do is we don't give any estradiol whatsoever. And once we are sure that there is a nice thickness of endometrium, so it's only in regular cycling women, we start progesterone for 5.5 days. And what you're going to notice by this strategy is that you still have a corporeal lutea, that you still ovulate, and that your pregnancy rates are exactly the same. So we're going back to giving progesterone because this modified artificial cycle showed you that even if your Ovitrel didn't work, your progesterone will. And that's why we're a little bit going back to giving progesterone. I think that when Ovitrel worked, you don't need it, but we're giving it systematically.
So what, you're starting progesterone 2 days after Ovitrel?
Yeah, so we started not the day after, we started 2 days after. So as you do with the pickup, yeah.
Yeah, all right, fine. What I do is I do HCG trigger, and then on the day of transfer, just out of curiosity, I measure certain progesterone level. I don't know how it is reflective. I still have questions in my mind about Elena's data. Okay, like those thresholds are in a way arbitrarily selected based on percentiles in the data set. Okay, not biologically. Someone says my 10th percentile was 7.5. The other says my 10th percentile was 9. And then you break up based on that, and I observe a difference, and this should be the limit. Okay, so the line of reasoning is not convincing for me at the moment. So I just want to observe, and we draw a blood sample on the day of embryo transfer, 7 days after HCG, and based on that inconclusive evidence, if it comes lower than 10 nanograms per ml, then I add progesterone. But I just want to see what percentage of women really, have those values. I'm not sure if it's beneficial. But what you do is, fine, it covers that base. Okay, it covers that base, and I don't think it will be harmful. Okay, and in the long run, your pregnancy and live birth rate might be higher than mine because for the few patients who would need it, you're covering that base. However, once you start it, you can't stop it. So for how many weeks those women, take those progesterone, and how do you give it? Is vaginal? Is it subcutaneous?
Yeah. So when we give progesterone, we always start vaginally. We start with relatively higher doses. We mimic what Elena does. So 400 in the morning, 400 in the evening. We systematically measure progesterone in both natural, fresh, and frozen cycles. And we systematically give injectable progesterone whenever serum progesterone is below 10. And this has been done since 2014. And we still show, and the ASRM data will show, that our results are getting better since we started monitoring and since we started giving progesterone, but that we're not compensating 100%. And another thing you're going to notice is that natural cycles almost never have low progesterone. But when they do, then you're in serious trouble. So mostly, and that is my fear, is that if you look back in the data, many of these natural cycles with low progesterone are cycles which you cannot prove for certainty that you had a dominant follicle to start with. So that follicle actually was producing estradiol, and that follicle was not a cyst or a periovarian cyst. Systematically, you will see that most of these cycles, the physician decided not to do measurements of hormones. And that's where I think you get into trouble in these patients, that you didn't really make them ovulate.
If there is no, no progesterone at all, then the endometrium would still look to laminar, right? So if that extreme, someone should be able to pick it up on the day of transfer. Yeah. But transabdominal ultrasound, sometimes it doesn't show to that.
Yeah, that's what I would argue, and so sometimes just by looking at the endometrium, you won't do it. You won't be interested in it, right? So basically, what you will be looking at is, am I putting the catheter in the right place? And sometimes you just won't pick it up, and that's why I think that measuring progesterone in the luteal phase, in the artificial cycle, without a doubt, I really think it makes a lot of difference. But I do need to tell you that we use different cutoffs than Elena, because our progesterone levels are different from Elena's. And so I don't think you should just transfer her data and just say it's true.
By the way, to remind the audience, Elena is Elena diye bahsettiğimiz insanı bizim mutasyon adı Labarta olarak duyduğumuz Elena Labarta değil. Alright. Bülent abi, başka soru, yorum var mı? Başka yerlere geldik ama hani ben de soruların daha ilginç olacağını düşünüyorum. Öbürü aslında straightforward yine.
I think it was an excellent meeting, Barış. Thank you for inviting Samuel. I learned a great deal. And Samuel, you're also a very good lecturer. Very nice, clear, concise. I loved your talk. Thank you very much.
I really appreciate it. I also learned a lot from you guys, and I enjoyed this discussion.
Thank you, and hope to see you in person in Istanbul sometime.
Me as well, indeed.
Yeah. All right, thank you. So, bu hafta da biz ayrılan sürenin sonuna geldik. Haftaya Perşembe'ye kadar herkes kendine baksın. Samuel, thank you. I'll email you later on.
Thank you very much.
Bye bye. Bye bye.
Cheers.
Hoşça kalın.
Görüşürüz.